My name is Javid Abdelmoneim. I'm a doctor. I work for MSF as a medical team leader. I am half Sudanese, half Iranian. I was actually born in the UK, but I lived my first 8 years in Sudan. And I joined MSF in 2009. So it's been 15, 16 years now with the organization. I've been full-time MSF for the last 4 years. Really enjoying myself working in emergency settings with the emergency teams. I first heard about the conflict in Sudan, I'll never forget it. I was in Malawi working just after the cyclone Freddy and during the cholera epidemic there. And I was at my desk and I got a cryptic WhatsApp message from my cousin in Khartoum saying, "Your dad's safe." And I just thought, well, this is weird. I checked the news and it said, and there were videos of fighter jets flying over Khartoum and said that conflict had started between RSF and SAF. So that was really quite shocking because it was very out of the blue. My whole family, Sudanese family, were there because many of them still live there, most of them still live there, but also it was Eid. It was the end of Ramadan. My father likes to spend Ramadan in Sudan. That's why he was there. And two of my cousins also had weddings due through Eid. So there had been a return of sort of family diaspora. So there were more of us in Sudan than usual. The war escalated instantly. It happened snap from that WhatsApp message on. It was throughout the whole city and then around the country because you had Rapid Support Forces, RSF, and Sudan Armed Forces, SAF, fighting for control of major cities, major routes, the airport, and people just needed to move out of Khartoum. It's not that Sudan has been free of war through my lifetime, but it's never been in the city. I didn't think in that first week or 10 days, I hoped this was going to be short. One of the sides would lose quickly, but it didn't transpire that way. And what ensued was just sort of collapse of a nation, total collapse of a nation, really quite suddenly. It was, I don't have the adjective, it was moving. MSF is able to work in Sudan all over the country on both sides of the front lines in both territories, RSF and SAF. Some of that work is a continuation of what we were doing before the war, but a lot of the projects are in response directly to the conflict, both at hospital level, at community level, but also in response to outbreaks of diseases like cholera, also for malnutrition. So not just direct violence related, maternal health, feeding programs. So when you look at the things that MSF are doing around the country, we're active in nearly all parts of healthcare, water and sanitation, preventative, maternity, malnutrition, surgery, on both sides of front lines, both in RSF territory and in SAF territory, be it in cities or even out in communities. So in my project in Omdurman, we were doing several things at hospital level and then at community level as well. So, and it was a period of transition. So I'll try and describe what we were going from and to. So we were providing in 3 hospitals, maternity, Saudi, pediatric Al-Buluk, and then surgical trauma emergency room, and now hospital. We were providing a package of care that was medical supplies, logistical, which was rehabilitation, minor repairs, maintenance, and fuel, incentivization of staff. So that means paying some amount of money. It's not a whole salary, but these are Ministry of Health hospitals, Ministry of Health staff who haven't been paid regularly at all since the war started. So in paying some incentives so that they're remunerated for their work to a degree. but also water and sanitation support. So rehabilitating sewage works, making sure there is water that's treated coming out of the taps. So that was the broad package of care in the hospitals. And we were transitioning into much more focused care. So whilst we kept the logistical water and sanitation and incentive and supply package, we wanted then to focus with our staff, our MSF staff, much more hands-on inside the emergency room of a now hospital and inside the acute malnutrition inpatient therapeutic feeding center, ITFC, in Al Bullock Hospital. And that meant having MSF contracted, MSF clinical staff in there looking at quality improvements. So we're looking at infection prevention and control, looking at proper waste segregation, looking at clinical knowledge of nurses and doctors, but also things like stationary trainings and systems. And one of those things is the mass casualty incident MCI plan of and now. So how does the emergency room and the wider hospital pivot instantly from business as usual to responding to a mass casualty? That's a very technical, should be a live document that needs input and co-development. So we were doing that as well. So it was amazing to go from reasonably hands-off, just keeping the hospitals going, to transitioning towards bedside clinical care quality improvement. The biggest challenges that were in front of us while we were there were about the context, but also about the sort of bureaucracies in administration and blockages, because where we were living and working inside northern parts of Durman is a safe area between two front lines within the wider Tri-City area of Khartoum. So the main challenge externally really is that you're in the middle of a conflict zone. You're in between two military forces shelling each other. You hear the outgoing and you hear the incoming across the river. Or even on Friday mornings, it's a bit quieter, traffic's a bit less. You hear the gunshots. The battle for Bahri, the Khartoum North, was happening while I was there. So it's close. And to put that into context or example, the emergency room in which we were working and supporting in a Nau hospital through January only had 3 days without shelling victims, right? So 28 days out of 31, we had shelling victims and we had mass casualty incidents, and it's random shelling. So it's not just that, there's also stray bullets. So the war is close and people you know are getting killed or injured, be it by shelling or stray bullets. So that's a major challenge in that context, because staff need to live and move around and safely work in the hospitals. And hospitals were a target as well. So, and now was a target and almost got struck a couple of times while I was there and had been hit before I was there. I'm the medical team leader, so I try not to be clinical. Actually, my day-to-day job is not clinical. I'm there to support and facilitate all the activity managers, the medical, the nursing, the midwife, activity managers, to do what they're doing. But I'm an ER physician and I'm trauma trained. So during mass casualties, and whilst it was a core function of MSF's work in and now to build together with the hospital administration the mass casualty plan, how an emergency room reacts to a mass casualty, because you have to understand that it's not just the ER that needs to respond when there's an influx of wounded that is greater than the capacity of the emergency room to handle alone. So part of our core work in and now was to co-produce that mass casualty plan with the hospital administrators. So I would whilst my nursing and medical activity managers would gladly go in and get hands-on patients, I would try to just sit above it and just identify who's the leader in this process, in this zone. How are we prioritizing which patient needs to go to operating theatre? So if I were to describe to you all the cases that I saw, they all died. That's because I was working with the blue and black cases. So I don't have a good story to tell in the sense of saving lives, but my push was, again, to make sure that they are comforted and having some dignity in their last minutes. And the second part of that was to make sure that the clinicians weren't doing too much for these patients to the neglect of the red patients who had a chance of surviving. The doctors know what they're doing, the nurses know what they're doing for each patient somehow, but you need a systems approach, because at patient level, if you are, and this happened, if you are transfixed with a really visible, nasty looking arm injury, but you haven't gone through your airway, breathing, circulation, disability and exposure system approach to the patient, you're going to miss the really life-threatening injury. Not only as MSF would we provide during a mass casualty, nursing, medical, some clinical leadership through, we would open our pharmacy, and other colleagues of mine, also nurses and pharmacy technician, would make sure we're constantly releasing extra dressings, what painkillers we have if we have it, plaster of Paris, cannulas, gloves, things that would run out during a mass casualty, because the emergency room itself had too small a supply room and it could only hold enough supply for 24 hours. So you're thinking on so many different levels. And beyond all of that, you have to, as I did, being the leader, responsible for the security of my MSF staff in that moment, where there's an influx of not only wounded, but intelligence services, concerned relatives, armed men sometimes, and the hospital is being struck in another mass casualty. You want to account for your staff members, but also keep an eye out, because if it gets too crowded and unsafe in the ER, at some point I have to say, we have to withdraw. It's not safe for us to be here. And we go back to our office, which has a reinforced roof and blast film, so that if there is a strike on the hospital, we know that that's a safe space. Otherwise, you have to evacuate the whole hospital. So my Sudanese colleagues have been in Omdurman working uninterrupted since the beginning of the war. You know, I've found in many places that I've worked that's like this. There's this sort of, the pressure, the siege mentality almost of working in a context like that, where there's a lot of stress and pressure, but the camaraderie that you build, the feeling of fulfillment that you get from seeing your work save lives, that combination actually brings about a very special sense of togetherness. And perhaps because, again, you know, Sudan, Sudan has only ever been good things for me. I had my childhood there. So there was also that layer, I guess. So together we had the wider team. I mean, we were nearly 30, 40 people, because we were also through a period of expansion hiring. A real sense of achieving something together in the midst of all that carnage. Our office in a now hospital is in a tiny little block, actually adjacent to the maternity building, which Saudi hospital was using whilst their site further south in Omdurman was being rehabilitated after it had been struck. So right next to our office, the next doorway was actually the mortuary. And the next doorway was the delivery room. So you had these most incredible sounds of death and life literally next door to each other. And the distances, the distances were, this doorway to that doorway. You're talking three meters. And so you'd be at the office, and families who would have to come to identify their loved ones, you'd hear the sounds of acute grief. And then if a baby was born, you'd hear the sounds of real celebration almost at the same time. And there's you may have heard that sort of Arabic trill or thrill, or when usually women do a very high-pitched lulling sound, and so you'd hear that when a baby was born, and or if you'd be walking towards the office, you'd see there's a tradition of taking the placenta home in Sudan, so you'd see the women sort of cooing almost over the placenta and the newborn hanging around the 2 or 3 trees that were in that courtyard. But you'd at the very same moment hear the wail of someone identifying the body of their recently deceased loved one. So it's the most bizarre experience, in a sense, and it's just, I had a few moments where I just paused, by the tree and just took it all in, I guess. Because for me also, being in Omdurman, I knew we were not far from where my family graveyard is, actually. So I went and I met the caretaker who knew many members of my family, and he described to me that the graveyard had been no man's land between the 2 front lines. And I just thought, oh my God, I'm going to walk in and see bones. I'm going to see graves that have been, but they were fine. And then I walked over to my grandmother, and again, poof, poof, the mausoleum, roof collapsed. All the trees had been chopped down. It was such a peaceful little garden. All the trees had been chopped down, no doubt by people for firewood. The walls had collapsed in 3 or 4 places. You could see where the shells had landed. And again, and the roof of the mausoleum in one corner. And I thought, oh no, what am I going to... Again, thankfully, all the graves were intact. So I took pictures. And while I was there were these huge booms. So it was, although it was cleared and safe, I think the booms were louder because I was nearer the front line going south. And so I was like, oh God, I can't stay too long. And of course, I didn't think about unexploded ordnance lying around. I really shouldn't have gone, to be honest. It was very naughty. But I just had to, for me and for my family. I've got the entire clan family living around the world now. There isn't an Abdelmoneim left in Sudan, except me at this moment, in the family graveyards. So I took pictures and sent it out to all my cousins saying, this is the damage, graves are intact, alhamdulillah, everything, like the ancestors, are okay. And so that was, you can see how I feel about that. Yeah. I hope for an end to the war in Sudan as soon as possible. It is Eid at the moment, and I wish next Eid that all my family have it in Khartoum. Personally, that would be amazing. Rehabilitation of the country. I think we've lost a lot as Sudanese. I don't know how close that is. I'm now waffling. But I think I said it with my first sentence. There you go.